how are you?
Yes. Oh, yeah, yeah, my dear. Yes. Oh, I can see you. How are you?
Hi.
I'm fine,
Ahmad.
sir.
Nice to see you all.
How are you?
Very good. Very good. Thank you.
Yeah.
So the two moderators for the day are Professor Ahmed Ali Shah and Professor Riaz Raja. Both of them you know very well, Atul.
Yes, yes. Ahmad, I can see. Riyaz, I can see. And it is a great pleasure and honor to be with all of you.
Same here.
The voice is little bit not very clear. Is that okay, Salman, for you?
Yeah, it's okay from my side. Is that, can you all hear Atul well?
Yes.
Riaz, can you hear Atul okay? Shasa,
Yes,
can you hear him all right?
We can hear.
Okay. So should we start, you think, Riyaz?
Yes, sir.
Okay.
Riaz, you want to introduce Atul, please?
Yeah.
Today's lecture by Professor Atul Goel and me and Professor Ahmed Shah. Professor Ahmed Ali Shah is moderating the session and I'm a co-moderator. We welcome Professor Atul Goel from India to present his topic on the cavernous sinus surgery. So should we start?
Yeah,
and we welcome to all who are joining us in this session.
Okay. Can you see my slides?
Yes.
Oh, okay, so let's begin, my dear friends. So what I have decided today is to take you through my journey with this beautiful, most astounding organ of our body, and that is called cavernous sinus. I must tell you that cavernous sinus surgery is not very old phenomena. Cavernous sinus surgery was almost non-existent in the era of CT scan and before that. Whatever surgery of cavernous sinus is done has been developed and advanced in the era of MRI, because it is here that we have been able to understand the arterial relationship, the dural relationship, and the exact relationships of cavernous sinus tumor. So my journey with cavernous sinus has been quite long, and I have presented on several occasions in Pakistan on this subject. And many of my slides are very old slides. I'm just going to take you through journey of my personal journey with this cavernous sinus. It is almost looking like a historical journey for me. So these are my 2 books which were published, and now 3 books are in line which will be published very soon. This was the book in 1996. And 1996 means about 24 years ago. And most of the techniques which I'm going to present to you are from during this era of mine, and how I have developed myself in this field of cavernous sinus. Salman?
Yes. What happened?
No, some imaging problem. Okay.
We cannot see your slides.
Yeah, I can see that there is some issue here. You can see the slides now? No?
No.
Not yet.
Wait.
No.
There is something from your end. You have disabled my screen sharing. Can you remove that disabling of my screen sharing? It is from your side.
Try again. Okay.
Okay,
so
now you can see, right?
Yep. This is good.
Now it's okay.
Okay, so this was my slide. So what I was saying is that during this time, cavernous sinus surgery was almost non-existent in the world of neurosurgery. Cavernous sinus surgery, Cliver's surgery have been born when the skull-based surgery as a discipline was born. And I was fortunate to be involved in these operations very early in my career. I started doing actually cavernous sinus dissection in the year 1986-87, when I was all the time in the cadaver lab doing dissections. And there my journey in 88, 89 actually started in the skull-based field, and how basically what I'm going to present to you is my personal work on this subject. You may be surprised to see this kind of a title of my slide, but in my several articles during that time, I have speculated in 1996 and during that time, speculated on the functions of cavernous sinus. And Dr. Riaz has seen my speculations on some occasions when I presented in Pakistan on this subject. Speculations means I speculated on what the functions of cavernous sinus might be. Cavernous sinus was considered to be a vestigial organ, not a single, very few articles were there in the entire literature about the functioning of cavernous sinus. Nobody knew what the functions were. So we had made several speculations, and I am presenting you these articles for you to be able to see them at a later stage whenever you have time, because these will be, I presume, on the YouTube. So these were my favorite slides, which I have been presenting for several decades now. Why the cavernous sinus of a lion is bigger than the cavernous sinus of a deer. You see, the deer's eye are located on the lateral side of the head. This is because of the special function that this deer has to do to save himself from the lion which is following him, and also simultaneously jump the various obstacles that the deer may have. So the eyeball moves up and down, front and back very rapidly. And these rapid movements are probably the reason why the cavernous sinus is bigger in a deer, because in a lion does not move the eyeballs too rapidly front and back, because he does not have to look behind. He's not bothered about the deers coming from behind or mosquitoes attacking from behind. He's just attacking this deer. So that was a speculation as to why the deer's cavernous sinus is bigger, because cavernous sinus is a hydrodynamic system. Eyeball is the ultimate of hydrodynamism in the whole body. The eyeball has to be under constant pressure. The vitreous humor, the aqueous humor, the lens have to be in a very, very constant pressure throughout their lifetime. So we had speculated that cavernous sinus has a big role in regulation of the hydrodynamics of the eyeball. We had also speculated that the cavernous sinus by itself has a role in eye movements. Like when there is cavernous sinus thrombosis, the eye movements stop despite the fact that the cranial nerves are present. In cavernous sinus thrombosis, the vision may be involved despite the fact that the optic nerve has no issues. So we had speculated that the cavernous sinus has a role in eye movements and vision apart from the cranial nerves. The relationship of cavernous sinus with sphenoid sinus mucosa, which is the most vascular mucosa of the body. The mucosa of paranasal sinus is so vascular, when the hot air or cold air comes inside the nose, as soon as it passes the nose, the temperature is normal. It is not high or low temperature in the trachea. Similarly, when the food or cold or hot fluid is eaten or swallowed, the temperature is here hot, but as soon as it goes in the esophagus, the temperature becomes normal. So this mucosa, this high power, highly vascular structure of the body is the air conditioner of the body. And this gives direct information to the cavernous sinus, and cavernous sinus gets information about the body situation from the carotid artery. And this information is relayed to the pituitary gland, and pituitary gland, the master organ, relays the information to the rest of the body. So these are some kind of speculations that we had proposed. And there are many other speculations which the young people will like to read. I have given you some articles of mine, so you please read them. So this is the most magnificent organ, very small organ, about 2.5 centimeter in the anteroposterior dimension and about 1 centimeter in lateral transverse dimension. So this is a very small organ, but right in the center of the brain. And many tumors are located around the region of cavernous sinus, like in the suprasellar area, in the medial temporal area, around the carotid artery, in the sphenoid sinus, in the pituitary gland, in the cavernous sinus. Despite the fact that it is a small organ, sorry for this, there are many lesions associated around it. So there is no way any young neurosurgeon can say that I am not interested in cavernous sinus. If you have to become a real technical neurosurgeon, you have to be interested in cavernous sinus. And you have to know the anatomy of cavernous sinus very fantastically. You have to know where is the sixth nerve, where is the fourth nerve. So this is the third nerve, this is the fourth nerve, this is the V1 division of the trigeminal nerve, this is the V2 division of the trigeminal nerve, this is intracavernous carotid artery, and this is the sixth cranial nerve which traverses inside the cavernous sinus. So what we had speculated ourselves, that these nerves have a dural wall of their own, and they are not directly in contact with the venous circulation. And I will now show you how these speculations have given us an option of devising our surgical approaches to these tumors. So we had said why the eye of a fish is bigger than eye of a human being, because eye of the fish is not only responsible for the vision, but is also responsible for balance, and also even in human being, it is responsible for balance. But in the fish, it is also responsible for swimming. So the fat, there is some fat content in the cavernous sinus. More, even in human beings, there is some fat. Even in most animals, there is fat. But in the fish, the proportion of fat is much bigger. And the eyeball is much more bigger and much more beautiful in a fish. So these are the fishes, eyes of various animals. And this is the human animal. We say it is not the eye which is responsible for your beauty. What lies behind your eye is more responsible for your beauty. People talk about your brain, but I talk about cavernous sinus. Cavernous sinus is a very, and I have talked on various other speculation. You see the beauty of the eye, and we must remember beauty lies in the eyes of beholder more than the eyes themselves. If you press your eye, this is also very old slide of mine. If you press your eye, for sometimes there will be diplopia, but then the balance occurs in both the eyes, then the eyes recover. So we had speculated the function of intercavernous sinus in regulation of the balance of the eye. Then there are several articles of mine for a very long time in 1995, 96, 97, means about 25 years ago. And this was the first time in the literature extradural approach to cavernous sinus was described for the tumors. This was the first article in PubMed which described an extradural approach to tumors involving cavernous sinus. We all know about the work of Vinko Dolenz in the field of cavernous sinus, and his extradural approach was for aneurysms. But this was the first article in 1997 which described the tumors. Then there are various tumors on cavernous, hemangiomas of cavernous sinus. I had talked about medial compartment of cavernous sinus. I had talked about meningeal architecture of cavernous sinus, and there are various kinds of technical papers you might like to read, but I'm going to summarize those papers for you today. So surgery on cavernous sinus has been my very favorite subject for several years, at least 32, 33 years. I'm involved in cavernous sinus surgery, and some of this work, which is shown here, you will like to read. Young people cannot say, I will not like to read. If you don't want to read, then listen to this talk a little bit better. So there are various other articles which will be on YouTube for you. And there are other tumors like aspergillomas of cavernous sinus, pituitary tumors, cavernous sinus, epidermoid cyst, teratoma involving the cavernous sinus, hemangiopericytoma involving the cavernous sinus, fungus involving, dermoid involving. So there are several articles of mine, tuberculoma involving, hemangiopericytoma involving the cavernous sinus, hemangioma, aspergilloma, and things like that. So there are many technical papers of mine, but all my technical papers have been based on one concept. And that concept, the young Pakistani neurosurgeons will be surprised to know that I have taken for the first time in the neurosurgical literature from Arabic legacy, not from any other cultural or religious mythology or legacy, but from Arabic legacy. And even Al-Mufti was very happy when I was presenting 30 years ago on this. Like membranes are the mother. Mandibular nerves does not pass through foramen ovale. It is the foramen ovale which is fashioned around the mandibular nerve. Essentially what I'm saying is the membranes come first, the nerves come second, and the bones come last in the embryological sequence. So we should be more relying on the strength of the membranes, which are the basis of our development. So dura is durable. I will come to that Arabic legacy very soon. So I work in a hospital in Mumbai, which is like where Rashid Juma was working at that time, in a public hospital like Jinnah Hospital. And I have visited that hospital. I have visited Salman's hospital. And you know, these hospitals are the meccas of neurosurgery in the whole, for the whole world. And if you do not use these meccas of neurosurgery, then it is not the mecca that is wrong. It is you that is wrong. Such high power, I don't think I was supremely gifted, but this hospital where I'm working for last 38, 39 years, and I am head of department for 24 years, KEM Hospital is the one which has made me. And there are several beautiful tumors that I have operated for a long time in my career. This tumor I had operated, I think, in 91, 92, and you see the massive approach that I had taken. And I have a 15-year follow-up for this lady who was blind before the operation. She remained blind, she was alive, and she used to cook chapatis. A blind lady cooking chapati, you cannot imagine, but that is a truth. And she was doing that. And I asked her to do a repeat scan. She said, "Doctor, excuse me, I don't want to do any new scan." This is another tumor I had operated in 1995 with a very extensive, massive exposure. Another tumor, I left some tumor behind. And this tumor, this patient was a one high-profile patient of mine. And I had shown this tumor on several occasions. So this is the sentence I got from Arabic world. Alum al-Dimag. So Al-Mufti corrected my pronunciation. I was calling it some difference. The meaning is the meninges are the mother of brain, the meninges. We should know that the tumors respect the meninges. Brain is nothing but sunken skin. What a beautiful sentence I'm giving to you, my dear young friends. So this was the approach which I described in 1993, 94. I published it in 97. extradural approach to tumors involving cavernous sinus. Cavernous sinus is an extradural entity. You can come extradural and approach these tumors outside the dura. You don't have to tamper with the brain. You have to retract the brain if at all, but you can come extradural. That is the best way you can avoid injury to the cavernous sinus. So this was my approach. This was one of my very beautiful articles where I said that you can diagnose the tumor on the basis of arterial relationship. Like this tumor has encased the artery, internal carotid artery, but this one has squeezed the artery. This one has encased, but it has not squeezed. This is a meningioma. This one has displaced the artery. So on the basis of the relationship of carotid artery, this article of mine was quite heavily cited during that time. I'm showing you this tumor. I can tell you this tumor is one of the most vascular tumors of the body, one of the most benign tumors of the body. This is not a pituitary tumor. This is not a meningioma. This is cavernous hemangioma of cavernous sinus. This cavernous hemangioma of cavernous sinus arises entirely within the confines of the cavernous sinus. The dura of the lateral wall, it is completely within the cavernous sinus. Dura of the lateral wall is never transgressed by the tumor. It goes near the orbit. It goes near the Meckel's cave. It goes into the intercavernous sinus towards the opposite cavernous sinus. It has a clear dural boundary from the sella and from the pituitary gland. It encases the internal carotid artery. It displaces the fifth and third and fourth nerve around the dome of the tumor. So this relationship I had first described in the year 1992, and this paper, this picture was amongst the first pictures of this tumor published to show post-operative resection of this tumor. So these are very heavily vascular tumors, but these are benign tumors. Patients come with eye movement disturbance, and if you remove them carefully and beautifully, and if you are able to handle bleeding during your operation, you can get back the eye movements. So for these tumors, this was my first article in the literature, which we describe hemangiomas, which are entirely intracavernous. You can remove these tumors by an extradural approach. And I had described 13 cases at that time. And this was, there is no question, this is now several people in the world are following for these specific tumor with these specific guidelines, with these specific radiological markers. Brain is not tied, the brain is relaxed because these are chronic benign tumors. You can come extradural, work within the cranial nerves, and then resect this heavily vascular tumor, first save the sixth nerve, and then work in the confines of the tumor. So this is preoperative scan, beautiful, it looks beautiful, but it is not at all beautiful during operation. The main thing that a neurosurgeon should learn, and a young neurosurgeon should learn, to handle the tumor amidst bleeding. While it's bleeding, you should know how to break into the tumor. And if you will say, I want a clean field, then you please do not touch these tumors. These are dangerous and difficult tumors. The issue is, this is the preoperative eye movement restriction, complete third nerve palsy, ptosis, and postoperative. Her hair have also not yet come properly, and she has got returned all eye movements. So this surgery is the only way you can get these young people to get their vision back, eye movements back, headache. These patients are essentially present with headache. And if there is severe headache, this is the only treatment. Otherwise, the headache will persist for the lifetime. You have to do this surgery very carefully and very philosophically. The other thing I am going to show you is the pituitary tumors. I have no hesitation to say that I revolutionized pituitary tumor surgery. You will ask me how I have revolutionized pituitary tumor surgery. So I will show you how I have revolutionized pituitary tumor surgery. So several years ago, this article of mine was published. And we said for the first time in the literature that the diaphragm celli is elevated by the tumor. Before that, the concept was the tumor transgresses the diaphragm from its hole and comes out. First paper in the literature where we said that the diaphragm is elevated by the tumor. So even if the tumor goes near the corpus callosum, the diaphragm celli is elevated by the tumor. You work within the tumor, remove the tumor, remove the tumor, remove the tumor, the diaphragm will ultimately come into the picture. Before our description 25, 30 years ago about this diaphragm, these kind of tumors were all operated by transcranial route. Whether you use microscope or endoscope, that is different, but the philosophy is that I remove just anterior wall, break into the tumor, the whole diaphragm comes into your field. When the tumor involves the cavernous sinus, it never transgresses the lateral wall of the cavernous sinus when it encases the internal carotid artery. It never transgresses. So this was also described by me about 25 years ago, that they can go into the cavernous sinus because medial wall of the cavernous sinus has some special architecture, but lateral wall is thick, never beyond the lateral wall. And when I published, there are several articles which were published saying that this and that and that and this, but you can read in the literature. So grade 2 was when the cavernous sinus was involved by the tumor, diaphragm is elevated, cavernous sinus is elevated. These are grade 2. Grade 3, beautiful, when the dural roof of the cavernous sinus is elevated.
Hello? 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 Atul has disappeared on us.
He's disconnected.
I think I'll just call him, see what we can do. He's back. Atul, are you there?
Yes, Salman, I'm back. Sorry for this.
No problem.
You know, I'm working from house and my connection in the house is not such great. But let me see, it has a little bit.
Atul, surgeon like yours should have a
Just a minute,
fantastic
Salman.
link everywhere.
You can
Wi-Fi
hear me,
should be the
Salman?
best for you.
Okay. So can you see the slides now, Salman?
Yes, yes, we can, but you
Yes?
have to open it up. Please make it slideshow.
Okay, so the dura of the cavernous sinus is elevated over the dome. So it was also one of the very major contribution of anatomical contribution.
Yeah, go on.
See, the diaphragm is elevated here. The dura of the cavernous sinus is elevated, dura of the roof. So this is the first time we described about 20 years ago that there is a method in this madness of pituitary tumors. It is not a haphazard extension. So the dura of the cavernous sinus roof, dura of the diaphragm, dura. So dura is the king, dura is durable. It is extremely rarely that these tumors go beyond the beyond the dura and encase the arteries of the circle of Willis and go beyond. It is present, but relatively rare. So if you have to design the surgery, you have to know that dura is elevated, and this concept has completely revolutionized pituitary tumor surgery. Just open the anterior wall, come into the tumor, debulk the tumor, and ultimately the whole diaphragm will get down. So we have several tumors like this. And as you know, this hospital of mine, KM Hospital, is like an industry of tumors. And this was, I had operated in the year 2001 from the nose completely with the microscope, understanding that the dura will be present. And I removed this tumor in 2020 years ago. This is another tumor I had removed in 1999, 21 years ago, just removed the anterior wall. And this is the post-operative scan blood. And this guy returned to me after several years with a recurrence, but this was immediate post
Atul, are you there?
Yeah, sorry again. You have to just bear with me, my dear friends. Okay, tumors involving the cavernous sinus is another cup of tea. When to remove tumors involving cavernous sinus, whether to remove tumor involving cavernous sinus are big issues. Non-functioning tumors, many of these are non-functioning tumors. Of course, if it is a Cushing disease, you have to remove tumor involving the cavernous. If it is acromegaly, you might give radiation, but radiation is not the answer. If you can remove surgically, that is the option. It is difficult for me to go into, going into the roof of cavernous sinus, you can remove, but the third nerve can be in danger. So the tumor consistency, tumor vascularity will indicate whether you can remove these tumors or not. When the tumors transgress the diaphragm celli and encase the circle Willis arteries, then it is a different game and different nature of these tumors. So many of these articles are published in various books and journals, and I wish you can read. Now I will go rapidly to my another favorite subject, that is trigeminal neurinoma. You must know trigeminal neurinoma surgery was not very extensively done 25 years ago, and several of my articles which you will see, this was the largest series published on trigeminal neurinoma at that time, and now my series is nearing 300 cases of trigem, which is also the largest in the world. In this article, for the first time in the literature, we describe interdural approach to trigeminal neurinoma. We describe for the first time that trigeminal neurinoma arise in the region of Meckel's cave. We also describe for the first time as a series that trigeminal nerve function can improve after surgery in these tumors. These tumors are dumbbell-shaped or only in the lateral wall of cavernous sinus. They never go into the confines of the cavernous sinus. This concept has completely revolutionized trigeminal neurinoma surgery. And you must read these articles, beautiful articles. These tumors are within the lateral dural wall. Work within this tumor, work within the confines of the dura, and you can remove these tumors in 20 minutes. Sometimes I remove them in 15 minutes. These tumors, you must know how to remove, how to debulk these tumors, how to break into the confines of these tumors. Early in my article, we had said that these tumors are part of the tumor is subarachnoid in location, but my recent work says that many of these tumors are also within the confines of the dura. So this slide of mine is a very old slide. I have presented this slide at least 250 times in various lectures of mine, that this is within the dura. The internal carotid artery is displaced by the tumor. The cavernous is displaced by the tumor. This we had said is subarachnoid, but now I feel that a large majority of tumor, this is also within the dural confines. So these tumors were removed in 2 stages earlier in my own lifetime. And 2 stages were described. This I had done several years ago in 2 stages. First, I removed the middle fossa component, then I removed the posterior fossa component. But when our understanding of the dura came into picture, we removed some of these. This was one of the landmark article of mine when I removed this tumor 25 years ago. I published this article when I remove a trigeminal neurinoma without doing any craniotomy, just widening the foramen ovale, infratemporal fossa, interdural approach. I don't do this approach often, but I describe this, and I think this is an important article in the history of trigeminal neurinoma surgery, where I removed this kind of tumor without opening the skull. This was the tumor without opening the skull for the first time in the literature. Now I do this kind of exposure for large trigeminal neurinoma, basal extension of subtemporal craniotomy I had described, where I removed the root of the zygoma, roof of the external ear canal, roof of the condyle, partial mastoidectomy. Now I do not do I do sometimes for large chordomas and petroclaval meningiomas, but not for trigeminal neurinomas. So this was another article where it described even the extracranial part of the tumor is within the dural confines. You can remove it transcranially, you can remove it transnasally, but transcranial reverse skull base is an option. More important thing was this part of the tumor is also within the dura. These tumors arise within the trigeminal Meckel's cave. This is another tumor, C2 neurinoma, which is similar to the gacillian ganglion. This is C2 ganglion. These tumors arise within the C2 ganglion. C2 ganglion is behind the atlantoaxial joint, and these two tumors are very similar in each other. This is the C1 arch, C2 ganglion. These tumors arise within the C2 ganglion, and they initially, I had described that trigeminal neurinoma and C2 ganglion are absolutely similar. There is a location interdural, and this part is located in the subarachnoid space. But in my subsequent articles, I described that even this part is also interdural in location. Like trigeminal neurinoma, you can work within the tumor, work within the interdural space, and many of these tumors can be done in very quick time. You can imagine 20 years ago, I did these tumors, 1998. So 22 years ago, I had done these tumors. Now I go to another tumor for you. This is a third nerve neurinoma. Third nerve goes, there is an oculomotor cistern over the roof of the third nerve. And these tumors, I had said that these tumors are also within the dural confines. If you preserve the dura, demolish the tumor, learn the art of breaking the tumor, you can preserve the third nerve function in these cases. So this is the tumor. Work with this tumor. There is no tumor capsule here. If you think it is tumor capsule, you will certainly demolish the third nerve. Work within the dura, work within the tumor. You see, this is necrosis within the tumor, and you have, this is post-operative scan showing complete preserved third nerve, which has never been shown in the history of neurosurgery. Third nerve neurinoma, you can preserve the eye function. So there is an oculomotor cistern here for the third nerve. Like Meckel's cave, these tumors arrive in the cistern, and the dura remains intact. And this is what it shows, interdural oculomotor neurinoma. I think if you have this concept, these tumors are absolutely not difficult. Don't remove the capsule, because it is not a capsule, it is dura. These tumors arise in the third nerve, and understanding that the third nerve can be preserved in these cases is a very beautiful concept that you have to learn. The dura of the tumor is intact in a huge majority of these cases. When the dura is not intact, it encases the schwannoma, encases the internal carotid artery. These are sixth nerve neurinomas, which are extremely rare, but they can be present. Of course, you have to have different style of removing a sixth nerve neurinoma. Then another beautiful article of mine on seventh nerve neurinoma, we said that these tumors arise in the region of geniculate ganglion. They are interdural in location. And when you remove these tumors, you work within the tumor, save the dura. This is not the capsule of the tumor. Save the dura, save the traversing seventh nerve, learn the art of breaking the tumor, and there is a possibility, there is not only a possibility, there is a distinct possibility of saving the facial nerve function in these cases. Another beautiful article of mine was published in 1995-96, where I said that the carotid artery, chordoma, this is a chordoma. Chordoma is a tumor which has a power to demolish the bone. It has a power to kill the bone, but it has no power to kill the soft tissues. So it is always an extradural tumor. It displaces the internal carotid artery anteriorly. It displaces the cavernous sinus superiorly. You work within this tumor from a lateral perspective, and you can remove, the dura will help you in removing this tumor. So this was the first time in the literature we said that these tumors are soft tissue displacing tumor. And this was the article published in the year 1995, where we said that the carotid artery, which should be here, has been displaced anteriorly along the anterior dome of the tumor. So there is no artery in this part of the tumor. The petrous apex bone is destroyed. So lateral attack, lateral shot on this tumor is a fantastic shot on this tumor. cavernous sinus is displaced on the dome of these tumors. So middle fossa subgastrian ganglion approach to these tumors, which I described in 95, is one of the most philosophical approaches to clival chordoma, which have a special architecture, special design. This tumor, when it artery is anterior, you must know that this is internal carotid artery anterior. So this is a chordoma. When it is a chordoma, you must know that the dura will be intact. This tumor I had removed in 20 minutes because of the soft nature of this tumor. You, of course, you have to drill the clivus and other things, save the sixth nerve, other things are there. But understanding of the concept that the dura is going to be intact has completely revolutionized this tumor surgery. Paranasal sinus tumors are also distinct. Nasopharyngeal angiofibromas are one of the most dangerous, difficult, and the most benign tumors of the body. Highly vascular tumor. The concepts were never clear about cavernous sinus and nasopharyngeal angiofibroma. We said that cavernous sinus is displaced on the dome of the tumor. These tumors are not only extracranial and extradural, but they are also extracranial. So there is a thin shell of bone which is present here, and you can have a very nice plane of dissection. This tumor is on both sides of the bone, and that is the hallmark of these tumors. On the basis of anatomical description, we had described a transcranial route for these tumors. Of course, I don't do trans in 1992 or 93, 94, I had described, but now I do mid-facial degloving approach for these tumors, but this was a very fantastic anatomical approach. There can be several other tumors like trigeminal. This is an epidermoid tumor involving the cavernous sinus within the dural confines, aspergilloma around the cavernous sinus, tuberculoma inside the cavernous sinus. But now I want to talk to you for briefly about the meningiomas, which is the tumor of the mother dura. It is the only tumor which goes on both sides of the dura. Or malignant, highly malignant tumor will go on both sides of the dura. But this is one tumor where your absolute philosophy of neurosurgery will come into picture. When to remove intracavernous part of the tumor, when not to deal with the intracavernous sinus is a great learning process in your field of neurosurgery. How to remove this tumor, whether to remove this tumor. I had removed this tumor about 25 years ago. At that time, I had demolished the cranial nerves of this patient. He's still alive, but all his cranial nerves are still gone. I am wondering whether this part of the tumor could have been left behind. This patient still comes to me in an intact condition other than his eye is closed. So earlier in my experience for all meningiomas, I used to do a very radical exposure, cutting of the greater superficial petrosal nerve from middle fossa approach, and mobilizing was first described in an article on this subject, on several articles which I'm showing you. But now, of course, my approaches have become much more confined for petroclival meningiomas. I think one of the most beautiful approach which I described for the first time in literature is lateral supracerebellar approach for these petroclival meningiomas. And one of the most astounding approaches I described in 2004 with 28 cases, now have several cases with supracerebellar approach. I don't need to come transpetrosal. I don't need to do orbitozygomatic osteotomy and petrosectomy for these, which I was doing on a very regular basis earlier. Many of these cases can be removed in quick time. Now I say in my neurosurgery that all tumors should be removed in all neurosurgery should be done in less than 1 hour, except glomus tumor surgery, bypass surgery, and AVM surgery. All neurosurgery, whether it is cavernous sinus tumor or petroclival meningioma or any craniovertebral junction issue, all neurosurgery should be done in less than 1 hour. I am saying that looks very aggressive statement, but this is what I have to say to young people.
You there, Atul? Hi, Atul. Atul, can you hear us? So we can see his screen, waiting for his voice. Atul, can you hear us?
Salman,
Yes, can you hear us?
I can hear you, but you unmute me from your side, please.
I don't know what happened.
Wait.
No, once it gets disconnected, it does that automatically.
You have to unmute.
We can hear you.
You can hear me? Okay. Because it was from your end, you have muted me somehow.
No, what
So
happens every time we disconnect, everybody gets unmuted.
Okay, so now here, so what I'm saying is meningioma surgery is the king of all neurosurgery. There is no question that meningiomas, we learn through meningioma surgery, but we never can learn meningioma surgery in our lifetime. Philosophy comes first in meningioma surgery, and you must read my article. So in meningioma, curing is a non-issue in the treatment. We can never cure the meningioma. We have to symptomatically relieve the patient of a meningioma. Recurrence of meningioma, beautiful sentence I'm giving you. Recurrence of meningioma is independent of the extent of tumor resection. It is not the treatment, but cellular behavior that decides the tumor outcome. Every neurosurgeon should have a plaque in front of his clinic stating that there are some patients okay.
You're back on, Atul.
Yes. So what I have to give message to mainly to the young neurosurgeons of Pakistan, that every neurosurgeon should have a plaque in front of his clinic that is stating that there are some patients whom we cannot help. There are none whom we cannot harm. So this is the one message that I am giving you to the young neurosurgeons of Pakistan. So thank you, my dear Salman, and thank you, Riaz. Thank you, Ahmad.
Thank you, Atul. That was excellent.
Thank you, Dr. Goel.
I'd get Professor Ahmed Ali Shah to say a few words.
I think there is second of the
I have heard Atul in India, in WFNS conferences over the years. Of course, it's difficult to go to India now because of the visa and the present government, but before that, I used to go very often. And I've always been impressed by his approaches, and I'm glad that he's here today. And I'm sure our students have learned a great deal. Thank you.
Thank you, Ahmad. It is a great opportunity for me to see you. I think you are at home or you're at work?
At home. At home.
Okay.
Atul, there's a question.
Yes.
People are there is Nawaz from KPK from Khyber Pakhtunkhwa from north of Pakistan. They're asking that what's your experience of using Kuza with these kind of tumors, and what is your technique to control the bleeding?
See, what I will do is, if you give me more time, I can do it. But the issue is, the time is also an issue for you and for me. But QSA is a very fantastic tool. I don't use it. I don't particularly like it, but sometimes for micro QSA I use it. But to tell you the truth, I have QSA in my department for several years, but I don't use it. But I don't say that you don't use it. You must use it. Young people may use it, but I don't use it.
Hemostasis?
Hemostasis,
sorry.
Dr. Goel.
I will give you another very beautiful technique of mine, Salman. My technique of hemostasis is hemostasis without hemostasis. And several of my cases like acoustic tumor, I have operated and I have removed the whole tumor. There is not a single time bipolar instrument has come into picture. There are several tumors I remove, like for craniovertebral junction, I do the entire operation C1, C2 fixation without once cautery coming into picture. There are several tumors where there is no hemostasis. Of course, I'm not a fool. If there is a spurter, I will not coagulate that. That is not the way. You have to coagulate when it is necessary. But somehow, my technique over the period of time has developed, like for trigeminal neurinoma. I will say if for trigeminal neurinoma, you take a bipolar and go on bipolaring, that is an absolute useless thing that you are doing. In an acoustic tumor, if you are coagulating within the confines of tumor, I will say you are wasting your time. If you are coagulating inside the tumor, that is waste of time. If you are coagulating outside the tumor, that is a technical mistake you have made. In various meningiomas, if you coagulate on the dome of the tumor, you have made a very huge technical error. So you have to know, in our neurosurgery life, we develop how to control bleeding. You have to develop this art of controlling the bleeding. In ABM surgery, if you say in ABM surgery, I go on coagulating, you will never in your lifetime finish ABM surgery. You have to know when to coagulate, when to not coagulate, when to avoid, when to do Surgicel, where to put gel foam, where to ignore. Basically, you have to learn to operate in a very fantastic manner. And this art of operating has to be learned by your hard work and by your dedication to the subject, knowing the anatomy of the field where you are operating. So these are my messages to the young people, Ahmed. And these messages I have given, when the young people from Pakistan used to come here. I remember Riaz, now head of department of a very important hospital in Hyderabad. He came with me. He spent a lot of time with me. I think more than 2-3 months he was with me. And several other young neurosurgeons. Now, of course, they are senior in their own right, but they know my technique of operating. What do you say,
Okay.
Riaz? Can you give me a comment, Riaz?
Yes, I have worked with you, and I know that you did the surgery of the craniopharyngiomas with the small supraorbital craniotomy without
Somehow
any
yes, I have lost
problem, and evident that you did very well. Are you listening me? Can you listen me?
Atul, are you
Dr.
there?
Goel? Dr. Salman, can you listen me?
I cannot hear Riaz properly somehow.
Riaz,
Okay.
can you ask few questions which are there on the group chat? Riaz, is it possible for you to ask those questions which are on the group chat?
Salman, can
I'm
I ask?
asking the questions.
Sure.
The
I
role
think
of
let's
the
start with Shahzad. Shahzad, please.
LP.
Atul, since the stereotactic surgery came into being, has a number of your surgeries reduced? Has it affected the number of patients that you operate on?
Atul, can you
Did you
hear
hear
us?
that?
Atul, can you hear us?
My internet connection is weak, Salman.
Sure. Shahzad has a question for you.
Can you hear me now?
I'm working from my house. That is the reason.
Yeah, I can hear you. Can you hear me now? I think there's a problem there.
Yeah. What has happened is that even in Atul's center, slowly and gradually, they're doing more endoscopic work. And also they are, many patients also go for radiosurgery, although with Atul, he feels radiosurgery is not the way to go. So it's like Vlad Venice. Atul is of the same opinion that radiosurgery is not the way to go for any tumor.
Oh, really? The tumors that he has shown, they are very, very large. I'm sure in India there must be some patients with smaller tumors
Sure.
as well.
We will unmute Khalid Mahmood. Khalid, we would like to have some comment from you regarding what kind of tumors you'd send for radiosurgery.
Yeah. Hi, Atul. Very nice presentation by Atul. I would like to ask two questions from Atul. First is, how are you doing pituitary surgery nowadays? Atul?
Khalid, he can't hear you. That's why we're getting you in the discussion, is because he is not available at the moment.
Okay. So what would you like to ask? Okay.
So what I was asking is, which patients would you refer for radiosurgery?
Well, my referral for radiosurgery is very little actually over the years. I don't refer any vascular case like AVMs, which we can deal with surgically. That's the small size, grade 1, 2, or even big superficial grade 3 AVMs. So far as the pituitary surgery, I don't refer them at all for any radiosurgery. I think if there is a residual tumor, you should go back and excise it. If it's a craniopharyngioma, you have done the endoscopic excision and you really think that excising the small part which you want to leave behind would cause more morbidity, I think that perhaps you could make a case for a radiosurgery referral when we talk about the skull base. So I think for supracellular pathologies, my referral for radiosurgery would be small craniopharyngiomas which are left after surgery, which you can't excise, A. B, if there are maybe recently I came across a supracellular meningioma that was very hard. I mean, I was doing endoscopically through the brow craniotomy, and that turned out to be very hard. So I think if due to some technical reasons, you are unable to excise a supracellular meningioma, I think that could be another referral for radiosurgery.
I can see
Nasiru
here. Yeah, sorry.
Even if you have removed the meningioma completely, and it turned out to be grade 2, you would still give radiation of some kind.
Well, I think we usually go for post-operative MRI scan, and if there is no enhancement, I don't do anything. But if there is an enhancement, we can follow it, and if you can do surgery again, that would be the best possibility, because I mean, whenever you go for radiosurgery, it just stops or just slows the progression, but it would just not remove the pathology completely. So, and there are side effects, and then there's a cost issues as well. So honestly, in my practice, I have referred very few cases for radiosurgery, although we've got a huge workload for skull base tumors, especially pituitary.
Your pathologists are not very strong.
Atul, are you back?
Yes, my dear Salman, I'm back.
Good to have you. Okay, there are a few questions for you.
Yes.
How do you differentiate radiologically on a large third nerve and a fifth nerve schwannoma?
Yes. Most radiologically, more than that, you know, what we have to do is the third nerve schwannoma will come with a third nerve palsy or third nerve paresis. That is the hallmark. And trigeminal schwannoma will come with a trigeminal sensory loss, like wasting of the temporalis muscle, wasting of the masseter muscle, having numbness. These are the hallmarks of these tumors. I can say on the basis of radiology, you can 100% time you can diagnose a trigeminal neurinoma than other tumors. There are other tumors in the territory like petroclival meningiomas and other tumors, but trigeminal neurinomas are a very characteristic way of presenting by
Oh my God.
I have a question with Professor. Can I?
Sure.
Yeah.
Atul, can you?
Yeah,
Are you back?
Yeah, I am back. I'm sorry, but you know, I'm working from home.
Fine. It's okay.
And
It's all
my
right.
internet is not good at all here.
So
So
sorry,
this
let's
is
ask the question.
Yeah, the third nerve is a different entity for very rare tumor. Sometimes you can miss a diagnosis. But what I'm saying is, if there is a third nerve and you have diagnosed it as a third nerve, there is a very distinct way of removal of these tumors. Like you have diagnosed a like a pittus tumor. If you have a prominent seventh nerve weakness, you can remove this tumor in a very distinct, quick manner by working within the dural confines. Because in a pittus tumor, you can see it is a malignancy, it is some this, that. You can have a very huge problem in facial nerve neurinomas. And the question of preserving the dura, you will think that it is a capsule, but it is not a capsule. I think these are very, very important surgical uh, tips that we have to learn and we have to acquire.
Okay, there's a question from Yasser Hoti from Lahore. He's asking, what's the incidence of meningioma surgery recurrence after a surgery for cavernous sinus meningioma, and how do you minimize the recurrence?
See, what we have to do is, we have to learn to understand meningiomas. Meningiomas are like fingerprints. All meningiomas are different. The extensions are different, the involvement are different, the presentation are different, the surgical difficulties are different, the vascularity is different, and more importantly for us neurosurgeons, the recurrence rate is different. So what we have to do is, neurosurgery for meningioma is the highest level of our philosophical understanding of any neurosurgical work. We have to remove the tumor within the safety parameters. We have to be aggressive in our character. We have to be confident in our character as a neurosurgeon. But we don't have to demolish the nerves and all. So nobody can ever predict. You see, I used to say a long time ago that you can diagnose this tumor was a meningioma was good or bad only as a hindsight. After 10 years, you have removed the tumor. It did not recur. Oh, that was a good tumor. It recurred. Oh, that was a bad tumor. So only recurrence and the nature of tumor can be diagnosed as hindsight. Salman.
Okay, so there's another question from Carlos Mendes. He's asking, do you also use endoscopic approach? Have you changed yourself over the years? And in comparison to open approach, which one serves better for a, can you just go down there? For a nasopharyngeal fibroma?
Nasopharyngeal angiofibroma. First thing is, I will say, I'm not very familiar with endoscope. But in my department, there are people who are doing endoscopic surgery for various chordomas. And we have some people who are very good in endoscopic surgery for CSF leakage, for chordomas and things like that. But if there is any tumor which is beyond the dura, like tuberculum celli meningioma, if you say, I will do endoscope, I will say you are an absolute, I don't want to use bad words, Salman, because you are very polished people sitting there. But for me to use endoscope for olfactory group meningioma, for tuberculum celli meningioma, you understood what I have to say.
Yeah.
But for a nasopharyngeal angiofibroma, if you are very good, you see this, we used to take this incision here like in the face. Though that face incision was a very common tumor for nasopharyngeal angiofibromas that we used to do. But I will say that incision is completely historical incision now. We can do it by mid-facial degloving approach, and I use it mainly by mid-facial degloving by working with the idea that these tumors are not only extra cavernous, extra dural, but they are extracranial, and you can develop a very beautiful plane. I don't use any interventional embolization also for nasopharyngeal angiofibromas. For intracranial tumors, I use embolization today only for glomus tumor, and that also I am not sure whether it is necessary or not, but only one tumor I use. I don't use for any meningioma, any other tumor in my armamentarium, in my field.
Okay, there's a question from Nasiru Ismail from Africa, and he's asking, what is the state of dura in redo surgery? What is your surgical approach for trigeminal neuronoma, especially when they have calcification? And you can see Nasiru there, actually.
Yes, I can see. And I will give him one very fantastic new philosophy I will give him, and you please listen. You see, when you are operating on pituitary tumors and you are reoperating them, it becomes a little bit indisciplined tumor. But in trigeminal neurinoma, if it is a recurrence, a large recurrence, it still remains within the dura. That is the beauty. Oh, that beautiful. I've given you this sentence. I've never given any in my lecture up till now. First time that even a recurrence remains within the dura. Yes, Salman?
Okay. There's a question from Adnan Khalik from Lahore, and he's asking, carotid is either pushed laterally or encased. So what is your management? A carotid artery is either encased or it's pushed laterally. So what is your management difference between the two?
Yes, very beautiful question. I have written one article on management of internal carotid artery in cavernous sinus surgery. First thing I will tell you is, in chordomas, carotid will be displaced anteriorly. In trigeminal neurinoma, it will be displaced medially. In cavernous hemangioma of cavernous sinus, it will be encased. There is another tumor where the carotid artery is encased is meningioma. So many, and also, of course, in pituitary tumors. So it will depend on the nature of the tumor when you are operating, whether it is soft tumor, whether it is a resectable tumor. Basically, you are not allowed to damage the artery. And in that premise, you have to go on working. If you think you will damage the artery, you better run away from the. If you think you will damage the cranial nerve, you better jump out of the operation theater. You should not persist, oh, let me try to handle the carotid, let me injure the carotid. If you injure the carotid, then you are not a good, you are in situation. Because to suture the artery in cavernous sinus meningioma, for instance, in cavernous sinus meningioma, you break it, you will have very severe difficulty in suturing the artery. In cavernous hemangioma of cavernous sinus, on the other hand, if the artery is torn, you can suture it because the whole artery is in your picture in a very big way. On the other hand, if you damage, there will be only one option for you to sacrifice the artery. So you please, we have to be in our neurosurgical field. I don't say I don't damage the artery. I have damaged on several occasions, but we have to learn to avoid that damage and go to an extent that we are far distant, safe distance from damaging. Okay, Salman?
Yeah, so there's a question that, are you leaving some tumors deliberately behind because of the risk of complication, or would you go to get all of it out?
That is another very advanced question. See, if I will, you see, my philosophy is, and I recently gave one lecture on philosophy. Once a tumor, always a tumor. Don't ever think that you can cure the tumor and you can completely cure the tumor. We have to be aggressive in our mind, in our brain. We have to go for radical tumor resection. But if there is some doubt, if there is some possible danger, leave it. If suppose I am working near the third nerve and I am not able to dissect, I will be a fool if I dissect and damage the third nerve. So I will leave that tumor. If I am working near the sixth nerve and I will say, no, I will remove the sixth nerve with the tumor, that will be a very basic damage. In acoustic tumor, for instance, in acoustic tumor, you must read my article. I have said that in large acoustic tumor, which we get in our countries, to leave a small bit of tumor is almost always necessary if you want to save the facial nerve. You will say, I have removed the tumor. For what you have removed the tumor to? You see, you can, of course, you damage the facial nerve. Of course, we all are humans. We damage the facial nerve function. But we leave some tumor behind if it is going to hamper the facial nerve function. Salman.
The philosophy changes with age, I think.
Was that Ahmed?
The philosophy changes with age. As you grow older, you become more conservative.
We have to become more aggressive. But we have to, there is one ad in India, Tufani Thanda. You have to be Tufani, but you have to be Thanda.
Tufani the Jawani mein hogi.
We have to be tufani all our life, my dear Ahmed.
Okay, that's brilliant. I think we are done with the questions, and Atul was really fantastic. I thank the moderators, both Riaz and Professor Shah, and I'm really grateful for Professor Ahmed Ali Shah for coming here, even from home. Professor Khalid Mahmood, Nasri, and all the friends from all over the world who tuned in. It was awesome. And this is our next webinar, which is on Wednesday, is Azam Ahmed, Associate Professor from Wisconsin. And he'll be talking about endovascular, vascular specialty in neurosurgery. So instead of giving it away to the radiologist, we should be thinking about keeping it under our domain and also doing vascular and endovascular both ourselves. And that's the logic behind this lecture for Wednesday. And on Friday, we have Professor Henry Schroeder, who'll be talking about minimally invasive removal of pituitary tumors at that time and intraventricular endoscopy. Atul, your last words before we wrap up?
Was that?
Your last words before we wrap up.
My last word is that, you know, for young people, we have to be very proud people, but we cannot have pride in our character. We have to be ambitious, but we should not be ruthless. We should be working hard, and we should be working very hard, because we can give new life to our patients. We can give them a symptom-free life for the rest of their life. We can, on the other hand, we can harm them very dramatically. So this subject is a divine subject. This subject is where our action will completely decide the future of our patients. There cannot be any arbitrariness. We cannot have any kind of, we should be confident young people, confident, but we can never have overconfidence. We should be human beings. And that is my last message to the young people listening to me today. Thank you, Salman, and thank you, all of you.
Thank you, Atul. It was a pleasure. We will hopefully have you soon again.
Okay. Thank you. I will be happy to come
Thank
again.
you, everyone.
Thank you.
Okay.
Bye-bye.
Okay, thank you. Bye-bye.